Welcome to the second series of our Get Men Talking podcast, a Movember initiative that brings men's health to the forefront with candid conversations about prostate cancer. Our aim is to encourage men to go get screened for the disease, and hopefully we can help one man get an early diagnosis and treatment. We also hope to generally encourage men to speak openly about their physical health and mental well-being. I'm your host, Ella, and today we have Tim Batchelor with us, who will be sharing his journey with prostate cancer, along with Mr. Simon Bott, an experienced consultant urologist who will be providing a medical perspective on the disease. So Tim, why don't you kick us off and please introduce yourself?
Yes, so thanks, Ella. So I'm Tim Batchelor. So yes, I'm a prostate cancer patient from 10 years ago, and delighted to be here to be able to talk about this, which is incredibly important for men's health.
Yeah, thank you. And Mr. Bott, Simon, please can you introduce yourself and a bit of your medical background?
Yes, so I'm Simon Bott. I'm a consultant urologist. A urologist is a doctor and a surgeon, and we look after part of the urinary tract essentially. So that's the kidneys, the pipes down to the bladder, the ureters, the bladder itself, the prostate, and the external genitalia. And in that, there's a lot of things that can go wrong. So kidney stones, urine infections, men getting up at night to pee, as well as a different number of tumours. I worked at the Institute of Urology in London and got an MD thesis in prostate cancer. And it's always been a fascinating area of study for me.
Brilliant. Thank you both so much for being here. Tim, let's kick off with just telling us a bit about how you were diagnosed and how that led you to Mr. Bott.
I had an offer from the company to have a full medical, and you wouldn't turn anything like that down, and it was paid for by the company I was working for, so a really good benefit. And I went into that medical thinking I'm going to come out, they're going to tell me to lose weight, they're going to tell me to take more exercise, drink less alcohol, change my diet, and I came out with being referred to a urologist for a potential prostate issue. And of course the worst thing pops into your head when you hear that, and I was referred to one of Simon's colleagues, and who was going on holiday, ironically, and he said, I've got this great guy I can introduce you to, Simon Bott, and he can carry out all of the things that you need to have done. And that's how we met just over 10 years ago now.
And Simon, could you tell us a bit more about, firstly, something I don't know, what does PSA stand for?
So PSA stands for prostate-specific antigen, which it's basically a protein that the prostate produces. The trouble with it is that anything in the prostate will put the PSA level up potentially. So if you have a very large prostate, for example, then that will give you a higher PSA, even though you've got no cancer in that prostate. If you have a bit of inflammation or infection, or you've ridden a bike or strenuous exercise, all those things can potentially put the PSA level up a little bit.
I think you were very fortunate that your company pushed you getting an MOT and getting that PSA checked, which led to your early diagnosis. Obviously, you don't need to be in a company to go get your PSA tested. Simon, could you tell us a bit about how a man can get his PSA tested?
So any man over the age of 50 in the UK can get a PSA blood test. They just need to go and ask their GP for it. They should be informed about the pros and cons, because there are advantages and disadvantages. And once they've been informed about the pros and cons, then the GP is obliged then to do the PSA blood test, and it is simply a blood test. Mm-hmm. And one really good thing about the PSA is it can actually predict who's going to get prostate cancer, not just who's got it now, but who's going to get it in the next 20 years. So you can then use that baseline PSA test to predict whether you need to be tested again and how frequent you need to be tested. So previously everybody said, well, PSA is a terrible blood test. I think that's also because previously we didn't have a good way actually of diagnosing prostate cancer. Nowadays, I think the vagaries of the PSA test have been reduced dramatically by the fact we can do an MRI scan, which is a painless procedure where you go in and have a scan, and that tells us with a high degree of certainty whether or not you do have cancer. So I think the important thing to say about the PSA blood test is you may well not have any symptoms, but still have prostate cancer and still have a high PSA. So I'd encourage any man to get their PSA blood test over the age of 50 or possibly 45 if there's a family history or you're black. Unfortunately, black men are more likely to get prostate cancer, about twice the rate.
Wow.
And actually, we want to diagnose cancer when you have not got symptoms from the cancer. Many men, as they get older, will get urinary symptoms. They'll start getting up at night. It's very common. It's common to be slightly more urgent, so you have to hurry a little bit to get to the loo. So those are all common symptoms, but those are not normally due to cancer.
Well, how do you approach connecting with any patient for the first time?
When I see a patient for the first time with a high PSA blood test, every patient is very different. So some patients will have looked everything up on the internet, they'll have come to a conclusion, and other people will just put their head in their hands and say, I don't want to know anything about it, this is the worst thing that ever happened to me, and just try and ignore it. So you've got to try and build up a rapport with a patient. I hope I did that with Tim. So I normally start off by asking the patient what they do for a living or what they do in their spare time. And then you get a sort of gauge of the patient, get them talking. And then I ask them why they had a PSA blood test in the first place. So some people like Tim just had a medical and it came out of the blue. Other people have been thinking about it from worrying about it for a long period. Often I'm afraid these things are prompted by their wives or their partners, which is a good thing, of course. Prostate cancer is the most common cancer men get. And we still unfortunately have 12,000 deaths per year in the UK from it. So it's a really important disease to find. And it's something we can find early. It's something we don't need to treat. So sometimes it's just a matter of monitoring. So not everybody has to go through treatment. But if you do need treatment and you can be treated by what we call radically with a curative intent, in other words, to try and get rid of it forever, then it is very likely you will live a normal, full, healthy life.
I think it's the point about partners and wives and other halves and everything like that is really important. And Rachel was with me for pretty much every single appointment that I had. She was sitting there listening, and she put up with a lot from me during that time. Still does, to be fair, but I think that the point about what the other half is noticing is very important.
Yeah, it's great you had that support as well with you, because not everyone does, and it's great to have family around you to help support you in that way. And so, was Tim one of those patients that came was overly informed or did he not know at the beginning what to do?
Tim was very engaged in the diagnostic process. I think that's fair to say. I think it is very much a two-way conversation. So I always sort of break it down into four things. So the first thing I look at is when we've done a biopsy, how aggressive the cancer is. Secondly, we look at how extensive it is, so how much cancer have you got. The third thing is the patient's general health, and age comes into that. And the fourth thing is what the patient wants. And each patient will have a different level of all those four things. Tim was very much of the mind, I want to get all the information I possibly can. I want to talk to all the people out there I can talk to. He would make an informed decision. Other people say, Simon, you make the decision.
And Simon, how do you tend to tackle telling a patient about their diagnosis?
So the first thing about PSA is the vast majority of people actually have a normal PSA, so they don't have to go down this journey. It's only a small number. And the good thing in inverted commas about prostate cancer is that it tends to be a stepwise diagnosis. It's not just we do a scan and we find it. First of all, you have a PSA, which might indicate you have cancer, but it's certainly not certain. So a number of people have a high PSA and not have cancer. And then you do the MRI. And again, the MRI doesn't tell you definitely have prostate cancer or don't have prostate cancer. So, but at each point, the chances are going up. So you say to a patient, your PSA is high, you might have cancer. So that's sort of crossing their mind. Then you say you have an MRI scan that I'm afraid shows you probably do have cancer, but it's not absolutely 100%. And then you then have to do the biopsy to confirm it 100%. So at each point, you're sort of being warned that this is getting more and more likely until you actually say. So by the time you actually say, I'm sorry, the biopsies confirm you do have cancer, most patients are sort of prepared for it. So most patients don't react badly at that point. Obviously, it's disappointing, but often you can look at the scans, you can look at the biopsies, you can say, look, I'm sorry this is prostate cancer, but in the vast majority of cases, we can treat you and we can cure you. And I just say this is just a hurdle in life. We're going to jump over this hurdle and we're going to carry on and live and get to the end of the race. Sometimes it's not like that, of course. So sometimes it's a very difficult conversation. But I think what you can do is prevent those difficult conversations by getting checked early.
Yes, definitely.
Absolutely.
And Tim, how did you react when you first heard that your PSA levels were high?
I kind of, in my mind, I kind of knew, if you like, but it's that kind of catastrophizing, if you like. And I knew, but I wanted to know, if that makes sense. And I remember calling a very close friend of mine. He was the best man at my wedding. And I phoned him. I said, I'm really sorry that I've not been in touch lately, but I've got a bit of bit of a problem. And he laughed at me and said, pull yourself together, man, get yourself sorted out. And which was the advice that I needed at the time, I think. And very supportive, though he wasn't. But it was the push that I needed to kind of move and get something sorted and get something done. But yeah, it was, I won't lie, I kind of lost a lot of sleep. And I don't think at that point, when that came back, I don't think I'd troubled my family with it. I was kind of internalising it a little bit until I knew more. And that was how I kind of dealt with it, I think.
And do you still have your PSA levels measured now?
Yeah, I think we started off every 3 months, and then it went to 6 months, and now it's annually. So I think my next one's due in February. So I'm expecting the email from you.
He gets an email every year from me saying everything's really good.
Simon, could you take us through the diagnosis pathway a bit more and how it's changed from when Tim was diagnosed to now?
Yeah, so things really have moved on. So in about 2015, we did a study that showed that MRI is really good at picking up prostate cancer. And also it's good at telling people they haven't got prostate cancer. So we start off with the PSA that may be high that prompts the MRI. We do the MRI scan, and the MRI gives us essentially a black and white answer pretty much. If it's black, we think there's probably cancer. If it's white, we think it probably is not cancer. So if it's white, we say off you go and you need to have your PSA checked maybe at 1 year, maybe at 2 to 4 years, maybe never again if you're in that group that are very, very unlikely ever to get it. But if it's got an abnormal area in it, then we need to do a biopsy. You can't do a biopsy in an MRI scanner. So what we use is something called a fusion technique, where I draw around the prostate on the MRI scan and I draw around the abnormal area on some clever software. And I make a 3D model of what the prostate looks like based on the MRI scan with the abnormal area in it. And that all happens before the patient arrives. And then what we then do is either awake or asleep, we put a small probe up the backside, and that's an ultrasound probe. That enables me to see the prostate. So what I do is I draw around the prostate as it appears on the ultrasound scan, and then the clever software takes my 3D model from the MRI with the abnormal area in it and fuses it with the ultrasound image that I'm doing while you're having the biopsy. So I can see the MRI essentially on the ultrasound. And then I can then just put 3 or 4 biopsies through the abnormal area. Sometimes we take a few elsewhere just to check the MRI hasn't undercalled it. And then we just have a few little bits to be sent off to the pathologist. They look at it under the microscope and they tell me what it is. So that's changed quite a lot since the last 10 years.
27. Was it 27 or 30 that I had?
Yeah, you had a lot. And some places still do quite a lot of biopsies. I think increasingly we're having confidence in the MRI as calling all the cancer that matters. So that's what MRI is really good at doing. So that's how the pathway, I think, has changed. In terms of looking for more advanced disease as well, we've got better tests. So you didn't need any of these tests, but it's not because your risk of the cancer having spread at the point of your diagnosis were really low. But some people unfortunately have higher PSA or more aggressive disease or more advanced disease. And therefore we need to look and make sure the cancer hasn't spread before actually treating them. So there's something called a PSMA PET, which is available in most hospitals around the country now, where we can look to see if the cancer has actually spread with much more accuracy. It's always moving on. It's getting better and better. We're getting better at doing it. We're getting more accurate at doing it, but also it's less traumatic to you. So you, as you say, had 27 biopsies. Now I rarely take more than 10.
Wow. We hear a lot about AI being used to support diagnoses. Is that something that's happening in your world as well?
Interesting you ask that, because we're involved with a study looking at exactly that.
Oh, wow.
So we're now doing AI to look at MRI scans. So an AI can pretty accurately read an MRI scan. So an MRI scan is essentially a computer-generated image, and it can count those black blobs. It can see if you have a certain number of voxels or pixels with the which suggests prostate cancer. Then the AI can interpret that. And we're now doing a study to see if AI can compare one MRI with another MRI in the same patient to see if that cancer's got worse.
Amazing.
And we're hoping you're going to use the AI to draw around the prostate, to actually draw around the abnormal areas, so that I don't have to do that before you come and have your biopsy. So the MRI will interpret the scan and it will then help with the biopsy as well. So yeah, AI. I mean, it's not out there for routine use yet, but the next couple of years, I think it'll be used much more widely.
And so when Tim was diagnosed, you guys went into this pragmatic approach and thought, right, how do we overcome this hurdle? And then you went through all your treatment plans and then went on from there.
Yeah, exactly.
So it's weighing up those four things that we talked about earlier. So it was weighing up, so we had the biopsy result, and that tells me how aggressive the cancer is. We had the MRI scan that showed me how extensive the cancer was. Tim was otherwise fit and healthy. And then it was about Tim deciding what was his choice based on that. And based on the aggressiveness and the extent, I could say, look, there are a number of options. Sometimes you might say, like in Tim's case, look, this is not a very aggressive cancer. It's still a cancer that we probably ought to treat in a man in his late 40s, because I hope he'd keep him going for another 40 years. So therefore, we may not have to treat the cancer so aggressively, but we should still treat it. But if we're not treating it so aggressively, you don't have to have so much in the way of side effects. So that's the sort of discussion I have with all my patients. And very rarely do I say there's only one option here. It is a matter of options, and it's a matter of discussing what that patient expects and wants in terms of their treatment.
It's that balance between, quality of life and longevity, and I guess you cope with that on a patient-by-patient basis, dependent on the cancer.
Absolutely right. Some of the other treatments, like the focal therapy that Tim had, then we wanted the prostate gone, and we did treat the prostate, and the prostate cancer has gone. But I've left prostate behind in him, which could become cancerous in the future, possibly, and therefore he hasn't got the same definite treatment of his prostate cancer that somebody might have with an operation. But he's maintained his quality of life, and I think I'm right in saying you had none of the ill effects of the procedure whatsoever. It was virtually, he hadn't had a treatment at all, but his cancer's gone.
And in terms of treatment options, have they moved on as well?
Yes, they have. I mean, they changed with the advent of what Tim had, which is called focal therapy, sort of 10 or 15 years ago. But the treatments are all getting better. So if you have prostate cancer that is confined to your prostate or maybe just outside, you have a number of what we call radical or curative treatment options. Unfortunately, once it's spread beyond the prostate, we can't cure it, but we can control it normally for a number of years. But if we go to the prostate cancer that we're trying to cure, then you have options of, first of all, just monitoring in some people. Surgery, that means normally using a robot to take out the whole prostate. Radiotherapy, where we fire the x-rays from the outside in. Brachytherapy, where we put these little radioactive seeds into the prostate. All those treatments treat the whole prostate. And then there's focal treatment that came in about 15 years ago, that just treats where the cancer is. And that really came on the background of how we treat every other cancer in the body. And this was the same thing for the prostate, particularly somebody in Tim's case who's young. Things like erectile function is probably important, and that to put him through a procedure that may affect that was not in Tim's best interest. But in terms of advances in all the areas of curative treatment and in focal therapy, in surgery, we've moved to robotic. So that means we just make 4 or 5 little tiny holes across the tummy. You're in and out of hospital normally in sort of 36 hours. Because you've only got small cuts, you recover that much quicker. You're back to work that much quicker. It's an amazing bit of technology that has made the surgical procedure much safer, and you get over it much quicker with similar sort of cancer results. So I think that was a major advance. In terms of radiotherapy, then we're learning that we don't have to treat people for so long. So back in the day, we treated everybody for about a month, Monday to Friday. Now we are learning that not everybody needs that length of treatment. We're getting better at targeting the prostate. So nowadays you can actually have your radiotherapy in an MRI machine. So the trouble with radiotherapy is you're firing beams in from the outside. You're hitting other structures when you do that. And to start with, you do a CT scan to look at where the prostate is. The trouble is you can't do a CT scan every day on a patient because it's x-rays itself and that can cause cancer. So what you have to do is say, well, I know where the prostate was on day 1 and I'm going to hope it's there roughly in the same place for a month. And therefore you can't give massive doses of radiotherapy at each time you get it because you're going to give massive doses to bits you don't want to treat. And if you do that, you're then going to give rise to side effects. But if you do the radiotherapy in the MRI scanner, you're constantly scanning, you know where that prostate is. So if your bowel is full or your bowel is empty, or your bladder is full or your bladder empty, if the prostate's in a different position, the radiotherapy just stops. So that means you know you're hitting the prostate and the target each time you're giving it. So you can ramp up the volume on the radiotherapy machine, give a much higher dose, which then means you can then give the whole treatment in 5 days rather than 30 days.
Wow.
So that's a big advance in radiotherapy. There have been advances to brachytherapy where you used to have a scan and be measured up for your prostate size back in the day, and now you have all that in one go. You can do a sort of live insertion of the seeds, then do a scan and check everything's in the right place. And if you need to put a few more seeds, then you can do that. In terms of focal therapy, we're much better with imaging. So we know what the prostate looks like, which bits need to be treated and which bits don't need to be treated. You had HIFU, which is high energy focused ultrasound, where we, rather than fire the ultrasound beams in parallel, we put them to a point and that heats a very small area. And that means you can be very targeted with how we treat it. The trouble is it's quite difficult to get to the very front of the prostate in patients with big prostates particularly, but now we have different forms of treatment for treating the front of the prostate focally, just where we're just treating the abnormal area rather than the whole prostate. So we can use cryotherapy, which is freezing, and there are all sorts of other treatments you can have where we just treat the area of the prostate at the front. So there are amazing advances going on all the time, which makes the treatment more effective, but also more tolerable to the patient.
Absolutely, good news.
And should hopefully reassure men listening that there's always advancements going on.
Yeah, and I think we're also getting more confident at monitoring people now. We know it's safe to, in some cases, it's perfectly safe to simply monitor you.
And you were diagnosed 10 years ago, Tim. So I have a question of what is your relationship like with prostate cancer now? And do you still consider yourself a prostate cancer patient?
Yeah. The answer to that last question is yes, I think. It's there. Do I think about it all the time? No. Are there times when I do think about it? Yes. Having my PSA checked, I think in February is my next check. I'll be thinking about it and looking forward to the email from Simon saying that, all is good. And but yeah, I think going back to the advancements that are being made, I think it goes back to that point about options as well. You have options now, which is there are probably less options available to me 10 years ago than there are now, and good options with good outcomes. With the important, you can't have those options unless you get checked, unless you are, in that category. But it's really good to know that there are these advancements going on.
I think it's brilliant for our audience to see, like, Tim, you have such a full life. You are, I feel you can see that your quality of life hasn't been affected. You've got so much that you enjoy, and you've got, I think some people think that you can have all of these side effects, but that's not necessarily the case. So when you went for your first consultation, were you more bothered about the quality of life or longevity? Like, how did you approach that?
And I think this is really important because each patient, each man is different, I think, with this. And I went into it thinking to myself sort of three things. The catastrophizing piece is important because it was in my head. And it was like, is this going to kill me? To Simon's point, what options have I got? And what's going to change? And those are the three things that were really... And then the first one was kind of removed very, very quickly because we knew that it was caught really early, which is the important thing here. If you catch it early, you've got more options available to you, and that's the message from this, I think, about making sure that men get checked. But for me, going through that process of looking at those options and making sure that I understood what was going to happen to me and what the outcomes were going to be was really important. And Simon, it became a conversation. It became a chat. Most of the time, all of the time, I think. At the early stages with the biopsy and the MRI, it was like a bit scary. But it soon became very much just a conversation. What are we going to do? But a very positive result for me because it was caught early.
And obviously, a cancer diagnosis. I only want to touch briefly on this, but it's a physical condition. But there's also a lot of mental and emotional challenges that come along with it. what resources were available to you that helped you with those mental challenges?
There was a lot. Charities, UK charities. I spoke to. I called them up. Another cancer charity as well that Simon recommended. So I spoke to a nurse. I spoke to other men that have been through similar diagnoses to me, and that was really useful. Just having a chat with. I never met one guy. Was in Scotland, so I had a long chat with him, and those kind of things were really useful for me, because it was just chatting to people that had knowledge and understanding of what was potentially going to happen. So yeah, that kind of put my mind at rest. But yeah, through the early start of the process, it was tough, and it will be tough for anyone who goes through these kind of things. Really tough. But as soon as I kind of had that treatment plan in front of me, and I knew what was going to happen, it was like, right, okay, let's get on with it, get it done, and move on with my life. And yeah, that's what we've done. But it's always in the back of your mind, I guess. So that's why we've continued with the regular checks.
You found speaking to other people that had gone through the same thing really helpful, like being open about it. And I think that's something that men aren't always comfortable doing. It's really important.
And I've got a lot of, like my uncle, he had prostate cancer, so he had it removed 15 years ago. So there's a family link there. He's been amazing, just someone to sort of chat to.
Nobody is exactly the same, so I don't think you can necessarily compare your treatment with somebody else you might talk to, because nobody else will have exactly the same PSA, the same prostate size, the same priorities in life. But it is very reassuring that there are lots of people out there who you can talk to, both as patients and from the charities, exactly as you say. There's lots of literature out there, really good literature out there, mainly from the national charities. I would always encourage people to go to those sites, because they're completely unbiased. There's no marketing or anything else. There's no promotion going on. And they're really informative. They're really well written. They're reviewed by urologists. They're reviewed by patients. Yeah. So I think they're an excellent resource, as well as the more emotional support that we get from the nursing fraternity. Normally, I would offer patients the chance to talk to a specialist nurse. And they are very well informed about prostate cancer. That's their area of expertise, but they're much more involved in the emotional side, the impact that has on men, and perhaps exploring that better than some people like me, who may be a bit more surgical about the whole thing. So I think every patient gets offered that, a nurse to talk to as well.
Yeah.
Great. It's wonderful to know there are so many resources available to men if they get diagnosed, and patients throughout their journey in treatment.
But yeah, in a funny kind of way, it's almost, I'm not glad I went through it, but looking back on it, I'm glad I went through it in a way, because it taught me a lot about myself, I think, in the whole process, and how to cope with tough stuff, which, yeah, is important.
Well, this has been brilliant. Thank you both so much for your time. And I think we've opened a lot of really meaningful and important conversations, ensuring that men go and prioritise their health, and they should never be scared to speak up about their mental well-being, their physical well-being. Have I got any last few thoughts from either of you?
I'll leave the last words to Simon, but I think for me, it is that constant message of, be on top of your health, get checked, and if you find, it's like any disease, if you find it earlier, you've got better options, better treatments, better ways of dealing with it, and both physically and emotionally as well. So that's the message from me. Just get checked, and don't be. I know we've got Get Men Talking, but don't be fearful of it. Talk.
Simon?
Yeah, I would say don't wait till you have symptoms before you get checked. So that's not just your PSA. Get your blood pressure checked as well. If you're a man over the age of 45, get your PSA checked. Maybe check your things like your cholesterol and your other risk factors. And don't do what men are very good at doing, which is saying, I haven't got a problem, I'm going to carry on with my life. Be proactive, because unfortunately I see people on a weekly basis who just think, God, if you just had your PSA checked 5-10 years ago, you wouldn't be in this situation. I wouldn't be having this conversation with you. And as Tim says, the options are often greater if you pick it up earlier. So Tim had the choice of having focal therapy. He didn't have to have the prostate out. Whereas if we diagnosed him when he was 60 rather than 49, it might not have been that way. So I think it's important just to go out and do it yourself, because nobody's going to do it for you, I'm afraid. There's unfortunately no national screening program in this country for prostate cancer, but nobody's going to call you to have a PSA test unless you're lucky enough to have a medical or unless you go to your GP and ask for it. So I think you've got to be proactive, go out, knock on your GP's door and say, I need to have a PSA, please, once you've understood the pros and cons of having the test.
I couldn't have said it better. Thank you both so much. And thank you to everyone listening. Please go and speak to your loved ones, speak to the men in your life, and let's keep this conversation going and get men talking about prostate cancer. Thank you.